Start with.
Okay. All right. Well, hi everyone. Thanks for joining our discussion today on all things skin, hair, hormones, and menopause. I'm Anushree Kumar, and I have with me Dr. Sunaina Likhari, dermatologist. And we just thought this would be a great time um, to just discuss some concerns that both of us see in our patients. I have an internist perspective, and Dr. Likhari has the expertise of a dermatologist. If you have any questions or comments, please feel free to message us, and we'll try our best to answer them. So I'm an internal medicine physician who is also menopause certified, and I work at Vita Family Medicine. I have a passion for midlife health, women's health. At my clinic, I provide comprehensive care where we layer lifestyle medicine, traditional internal medicine, and of course, menopause and hormones to provide personalized and nuanced care to our patients. Dr. Likhari, tell us a little bit about yourself and your practice.
All right. So, first of all, thank you for setting this up. I know we've been talking about doing this for a while, and this is a topic that's very close to both of our hearts because we're personally experiencing some of these things, and we see this a lot in our patients. But my name is Dr. Sunaina Likhari. I'm a board certified dermatologist. Um, I'm also the owner of Sweetwater Dermatology. My practice is mostly medical dermatology, but I do a lot of cosmetics and surgical dermatology, and I see patients of all ages. But the two most common complaints I would say that I get are acne and hair loss. Those are very, very common complaints. And acne, not just in teenagers, but I see a lot of acne in women in their late 30s to 40s and beyond. So I'm glad that we have a chance to talk about this. And I see the external manifestations of these hormone changes, but it's nice for me to be able to hear and for my patients to be able to hear what is actually going on inside the body that's affecting this change on the outside. So I guess Dr. Kumar, with that, maybe you can start off and tell us a little bit about what's actually happening inside the body when we hit perimenopause. What is perimenopause? A lot of my patients don't know what that means. And is there an actual definition for that versus menopause? And how does this differ from what is happening in a young person who's having regular menstrual cycles, what's actually going on?
Yeah, of course. Menopause is defined as the point in time that a woman doesn't have periods for 12 months. Okay, so that's when we know cycles have stopped, and I think a lot of women know they're in menopause. Now, perimenopause is a little bit more of a flexible term, and it describes the entire period of hormone transition prior to menopause, where we actually stop having cycles. So this phase can last anywhere from a few months for some women up to like 8 or 10 years. That's what we're seeing in research. And a lot of people believe that uh, it seems to make sense that the estrogen production of the ovary would just decline over time and then kind of stop. But that's actually not what happens at all. So, a woman who is maybe in her 20s and 30s and having normal cycles and is of reproductive age, she has a very predictable pattern of hormone fluctuations. It includes, FSH, LH, estrogen, and progesterone. And they have this very rhythmic pattern, which produces our cycles, produces ovulation, and allows a woman to get pregnant. However, when the ovaries start to get quote unquote old, the hormone production becomes erratic. So one day the ovaries may produce a super high level of estrogen, and then the next day that level might go down to zero, and then the next day it'll be somewhere in between. And so you have this kind of roller coaster of hormones, which is responsible for a lot of the symptoms that we have. So we all know that there's hormone receptors in our ovaries and our uterus, etc. But research has actually found that we have hormone receptors in pretty much every organ system of our body. And so that includes like the heart, the joints, our gut, and definitely our brain. And of course, we also know that we have hormone receptors like in our hair and our skin. The other thing
Mhm.
that happens during perimenopause, especially, is we see a relative androgen excess. So while the ovaries are going crazy, they're not making stable levels of estrogen and they may not be making stable levels of testosterone. It's declining. The adrenal glands actually kick in, and the adrenal glands are also able to produce testosterone and estrogen. So they start increasing their production. And when they increase their production of hormones, you get this relative increase of testosterone as compared to estrogen and progesterone. And so a lot of the skin and hair manifestations that we see can be attributed to this discrepancy in the balance of the androgens versus the estrogens. So, systemic signs of hormones fluctuating. Of course, we all know like hot flashes, night sweats. So the thermoregulation is actually controlled in our brain, and the hypothalamus uses estrogen to keep our sense of hot and cold stable. So when the estrogen level goes up and then down, the body gets really hot and then they'll get really cold. This is also some other signs that can be attributed to perimenopause are like brain fog, sometimes heart palpitations, insomnia, and headaches, etc. So there's a lot. Yeah. So we're here to talk about hair and skin. So, Dr. Likhari, can you kind of tell us a little bit like what exactly happens like at the hair follicle level and at the skin level with our fluctuating estrogens and androgens?
Yeah. So, um, man, yeah, we go through a lot, right, when we hit our 40s. But
Yeah.
in addition to all the things that you mentioned, I have tons of patients coming into my office noticing, and it's very interesting because they'll notice just like one day, out of the blue, they'll wake up, they're maybe 42, 43, and they're like, I look old. Like, I don't know what happened, but I'm seeing sagging and wrinkles, and I just look older. And so I want to focus first on aging. And basically, as our estrogen, you mentioned estrogen kind of going crazy, but generally, like there is kind of a slow decline until you hit menopause, and then it really declines. And so, estrogen is responsible for our collagen production. There are estrogen receptors on the cells that produce collagen, the fibroblasts. And collagen and elastin are basically like a scaffold for your skin cells. So there's something called the extracellular matrix, which is just like this nice little jelly cushion for your skin cells. It helps to give us that plump, youthful appearance. It helps to give us smooth skin. And so when estrogen declines, we're making less and less collagen, and we actually start to lose 1 to 1.5% of collagen every year, starting in our 20s. Then you start to see the signs of aging. So fine lines and wrinkles, deeper wrinkles, even like hollowing out of some of our areas on the face. So you kind of lose like volume in certain areas. And you can also start to lose water. So as that extracellular matrix is kind of drying out, you have more water loss, transepidermal water loss. Basically, we lose moisture in our skin and we get dry. And then dry skin also looks more wrinkly. And I also see a ton of women as they're getting close to menopause start to develop eczema for the first time because their skin is dry, and they may be someone who never had eczema before, but all of a sudden they're getting itchy and dry. So all of
Yeah,
that's
and their skin becomes more sensitive,
for
right? Like
sure.
maybe more contact dermatitis kind of stuff going
Yep,
on. I've
yep.
seen,
Yep, and I'll have
yeah.
patients who get, yeah, exactly, contact dermatitis. Like they'll tell me, "Oh, I've been using this product my entire life," and I'll tell them, "Well, sometimes you actually can develop a sensitivity over time, and certainly that can happen with hormone changes." So, as far as aging goes, estrogen is what's playing a large role in that. The other thing we see, of course, during perimenopause is acne. And again, women who may have never had teenage acne growing up, all of a sudden in their late 30s to 40s, they are mentioning getting cystic acne along the jawline. These are deep cysts. They never come to a head. They last for weeks. They leave behind scars and dark spots. So they're distressing and painful to people. And so what's happening there, you mentioned that there's this fluctuation of estrogen, but androgen levels are kind of remaining the same. So
Mhm.
relatively, there's an imbalance that's kind of favoring androgens or the male hormones. And those hormones are very active in the lower part of the face, like the beard area. They are inflaming the oil glands there. So every one of our hair follicles has a little associated oil gland. And so that unit It's very sensitive to the male hormone, especially as we hit our 40s. So we'll start to see cystic acne in the lower face. And it's interesting because it's different from teenage acne that tends to affect the T
Mhm.
zone. That's
That's
kind of
true.
the, yeah. So the T zone acne usually starts on your forehead, and that seems to reflect the way that in puberty, our oil glands are kind of growing and developing. But in later in life, we see acne on the lower face, and that's very consistent with this adult female hormonal acne diagnosis. And if you're someone who's genetically prone to getting that, what I often tell my patients is you're probably going to be dealing with this for at least a couple of decades. If it's starting in your
Hmm.
30s, you're going to be treating this at least until you hit menopause.
Yeah.
Once you hit menopause, the acne and rosacea do tend to get better. Um, Again, that's because at that point, both androgens and estrogen are declining significantly. So you do tend to see an improvement, but for a couple of decades, you could be someone who's dealing with acne. Um, and the last thing we'll talk about is hair loss.
Hair
So
loss.
hair loss is a huge frustration for both patients and doctors because it's multifactorial, it's difficult to treat. But in terms of hormone issues, there's a few things that happen. One, of course, we've already talked about an increase in the male hormone activity at the level of the hair follicle. And there are receptors there that you may not have actually an abnormal level of androgens. Like if you did blood work, you may not actually see any abnormal hormonal levels, but the activity of testosterone and specifically dihydrotestosterone, DHT, is increased when you see female pattern hair loss. And female pattern hair loss is characterized by, a recession and thinning of the frontal part of the hair and then a widening of the part. A lot of women will say, I just see more of my scalp now than I ever did. I'm having tons of shedding. And so all of that is driven by that activity of androgens. But the other thing that happens, there's a couple of other hormone
Yep.
kind of things that are happening. One is there's a hormone called LH, luteinizing hormone, and that seems to really increase in perimenopause. And that actually causes direct damage. That increased LH level directly damages the hair follicle, which is interesting, um, almost like aging it, almost in the way that sun exposure ages and damages your skin cells. So
Yeah,
that
that's
hormone
very
plays a role. Yeah, it's
interesting.
really interesting. And as we
Yeah.
were preparing for this, like I read more about that, and that's actually a part of the pathophysiology that I haven't heard a lot about. And there aren't
Yeah.
many treatments that actually seem to be studying that one aspect of it. And then the other thing is the hair follicle is also very sensitive to estrogen, and as that's generally declining as you get towards menopause, the hair follicle kind of becomes quiescent, and the actual hair shaft diameter thins, the length, the duration of the hair growth phase, anagen phase, shortens. So we
Hmm.
get smaller, like miniaturized hairs and less of
Yeah.
them.
Yeah. So basically, the hormones affect every part of the hair growth, the
Yeah.
hair health,
Yes.
the hair cycle, and the
Yes.
follicle. Yeah.
Exactly. And then there's different types of hair loss, and that's something that people don't really realize. Everyone thinks that as they're getting older, they're naturally going to start losing hair. That's just part of aging. And yes, that is. That's kind of the hormonal milieu that we've been talking about. But you can also get other more inflammatory types of hair loss, and there's
Hmm.
different conditions that we see. One of them is called frontal fibrosing alopecia, and that is seen more commonly in postmenopausal women. It is thought to be due to that decline in estrogen and androgen levels. And what that is it's an inflammatory process where there's so much inflammation that it ultimately leads to a scar forming around the hair follicle. And if you think about like if you had a bad burn on your arm, you wouldn't grow hair there anymore because it's all scarred down. And that's kind of what I tell my patients. If you've had tons of inflammation,
Yeah.
such that you end up with a scar in your scalp, that hair is no longer that follicle is no longer able to produce a hair. So it's
Yeah.
essentially irreversible. So treating or diagnosing frontal fibrosing alopecia early and trying to stop that inflammatory process is what saves the hair follicle. And you
Hmm.
want to catch that early so it's not irreversible. But
Yeah.
basically, FFA looks like smooth, shiny hair. I mean, smooth because it's scarred down, large spaces in between the hair follicles, loss of eyebrow hair, and then some people actually get skin manifestations. They'll get like little bumps, little papules on the
Mm.
forehead. So that's something that can be diagnosed clinically a lot of times by dermatologists, but also we can do a biopsy to prove that that's the diagnosis. Um, and that's where early intervention is really important, early diagnosis and intervention. And then the
Yeah.
other thing we see is in your 40s, we see stress. I mean, women are busy, they're ramping up in their careers, they may be moms, they may be taking care of aging parents, they're not taking care of themselves, maybe their own nutrition status has gone down. And so we can see a stress-induced hair loss too, called telogen effluvium. And that's where you just see kind of massive shedding of the hair. And a lot of times, I always tell women that hair loss is more often than not, multifactorial. So you're kind of
Yes.
having to treat it in with multiple different modalities.
Yeah. Yeah, no, this is really interesting. And when people come to me, when patients come to me with hair loss, I definitely talk to them about the hormonal changes and the stress, the impact of stress and lifestyle. But the frontal fibrosing alopecia, it's very interesting to me that like in early stages, it can kind of look like just regular hair loss. And so I think it's just so important for people to always go to a dermatologist, make sure they're properly diagnosed and not missing something kind of irreversible, something that is potentially reversible before jumping to, other therapies and procedures. Yeah,
I
great.
agree. Yes, I agree.
Yeah, thanks for that. So, when it comes to treatment, because of course everyone wants to know, like, what do I do about all of this stuff?
Hmm.
We'll like just talk about some of the treatment options. So when I have patients, of course, they don't come to me with a primary complaint of skin issues or hair loss generally. And we talk about hair and skin more as part of their general health and evaluation. So I always tell patients like to divide the way they think about their health into like four different categories. And I think it really applies to a lot of complaints about midlife. So, number one, we talk about like chronological aging, right? And in that these are umbrellas that I made up. And so they're not like technical terms, but in chronological aging, I, often tell them like, look, there's a role of your genetics, right? What's going to happen to your hair and your skin. There is something that there is a part of that you really can't do anything about. There's also the cumulative effect of your exposures that, the sun exposure that you had, or if you had smoke exposure, pollution, etc., that's adding up. And when you hit your 40s and 50s, that's going to have an effect on your skin, maybe your hair. So we talk about chronological aging. The second category I always talk to patients about is lifestyle factors. So stress, sleep, nutrition, exercise. I mean, these are the pillars of good health when it comes to our internal body. But we always talk, right, about how your skin gets affected when you don't sleep well, or if you have stress, which you did touch on already, telogen effluvium. If you're not eating enough protein, I mean, I get patients who increase their protein intake and they'll tell me like, my nails are growing faster. And I'm like,
Hmm.
yeah, that makes sense. So you're probably also having positive effects on your hair and your skin.
Hmm.
Um, and hydration, of course, if we have to be well hydrated. The third thing that I always look at when it comes to evaluating skin health is medical conditions, right? We have to check thyroid, vitamin, iron levels, any chronic conditions, even hypertension, insulin resistance. These do contribute to not only your internal health, but external. And then, of course, the fourth category is hormone transitions and perimenopause. And so when it comes to perimenopause, I always look at um, kind of all the symptoms. We have to manage all the symptoms. Are there hot flashes? Is there brain fog? Are there changes in your period? A lot of patients don't know like how much of, yes, like my skin looks, we'll focus on skin. So a lot of patients are like, yeah, my skin is terrible. I'm losing a lot of hair. Is it menopause? Is it perimenopause? And like my answer to that often is that, yeah, like hormone transitions are probably playing a role, but they're probably not the only component of what's causing the changes in your skin and your hair. And when it comes to giving hormone therapy, there's very few trials and there's not really good data on whether hormone therapy actually will help our hair quality or skin texture.
Hmm.
But theoretically, if lack of estrogen causes damage, we do think that, of course, replacing estrogen may help. However, it's really important to note that the patients who seem to benefit the most from hormone therapy are the ones who have the strongest symptoms of
Mhm.
perimenopause and menopause.
Okay.
So, and this is not only true about hair and skin, this is true about a lot of different effects. Um, so if a patient comes to me and she's like, I have horrible hot flashes and night sweats, and I have a lot of brain fog, and my periods are all over the place. When I give them hormone therapy and those improve, we can also expect the maximal benefit in terms of hair and skin versus another patient who some patients come and they're like, I don't really have any of these symptoms, but I'm just tired and my skin is, I feel like I'm losing a lot of hair. Um, Hormones may be playing a role, but then we always have to do a deep dive and look at
Mhm.
everything else. Like what do your labs look like? What's your lifestyle like? And then sometimes those changes are more effective than
Mhm.
trying to replace estrogen and progesterone.
That makes sense. Yeah, that does make sense. All of
Yeah.
this is so
Yeah.
complex. There's so many factors at play.
So
So
many factors. And
to
so
tease
of
that out.
course, yeah, so of course, like I don't provide targeted treatment for wrinkles and thinning skin, but if hormone therapy, maybe a patient is on hormone therapy or hormone therapy is not the right option for them in other ways, for other reasons, like what do you recommend uh, for these women that come in?
So yeah, so I'll talk first about the aging piece. So people come in and they're noticing their wrinkles and lines and their skin is sagging. And just like you, probably the first thing we talk about is lifestyle modifications. Like what can we be doing better? And just like internally, your lifestyle makes a difference. It also affects your skin, right? So how hydrated are you? We talk about protein intake a lot for hair loss. It's a
Hmm.
really big one. And so kind of trying to maximize all of that. And then, of course, when it comes to your skin, I mean, the number one easiest intervention that you can do when it comes to anti-aging is wearing sunscreen. And that has nothing to do with your hormones, right? But we know that UV damage causes wrinkles. And so at the very least, getting a woman in her 30s to 40s who's never worn sunscreen daily to start doing that, that's such an easy intervention. That's the first thing I talk about. So people ask me, what should I be doing for anti-aging for my skin? And there's literally two things I say. If you want to keep your skin routine very simplified, and that's kind of my style, I don't think you need to spend hundreds of dollars on skincare. You need sunscreen, should be SPF 30 or higher, and you do need a retinoid. So retinoid is basically like a vitamin A derivative cream. Retinoids they're over the counter. You can find them in the form of retinols. You can also get them as prescriptions in the form of tretinoin. And so basically, vitamin A helps the skin cells turn over faster. So you get an improvement in like the skin thickness. They help to improve collagen production. They help improve blood flow and circulation to the skin. They help reverse UV damage. So they're kind of like they're the be all for anti-aging. So we talk about getting on a retinoid, starting sun protection. Then you can kind of beyond that, there's a lot of
Um,
treatments that you can do. Microneedling is anything that basically stimulates collagen is helpful. So microneedling is a procedure that we do where we have a device that has really tiny little needles. They roll along the skin. They cause a controlled damage to the skin, which then stimulates surrounding um, fibroblasts to produce collagen. So that's like a very easy procedure that a lot of people can do. It's safe in all skin types, even darker skin types. Um, we use a lot of platelet-rich plasma or fibrin. That is basically where we draw your blood, spin it down, and we use the portion of it that has a lot of platelets, which have growth factors that help stimulate, again, collagen production. That's not an FDA approved treatment. It's actually only FDA approved for use in orthopedics, but PRP has now expanded into a lot of other spaces, and there's a lot of data and evidence that it helps with wrinkles, and also we use it for hair loss. We can talk about that when we get to hair loss, but um,
yeah.
you can do microneedling with PRP or PRF, platelet-rich fibrin, and that's helpful. And then we can do, of course, injectable treatments, and one that I really like is called Sculptra. Sculptra is an injectable. We inject it under the skin just like you inject a filler,
Mm,
but it's not a filler. So filler is made with hyaluronic acid, synthetic hyaluronic acid, kind of mimicking
mhm.
your own collagen. Sculptra is actually particles of a dissolvable suture, polylactic acid. And yeah, and so you
Oh,
reconstitute it in
interesting.
sterile water. And so it's very dilute. And when you inject it under the skin, these little particles form, essentially serve as a scaffold for your fibroblasts
Oh.
and produce collagen. So Sculptra is one of those treatments where you don't see immediate results the way that you would with a filler. It takes
Hmm.
about 3 sessions of that over the course of a few months. And then it really takes your body up to 2 years to develop that and create that collagen. So it's a very slow, the results take time, but they last a really long time, often more than 2 years. So I like that. And I like to consider that in women who are in their 40s, because once you hit menopause, your collagen production declines pretty rapidly. So it's kind of nice to build that up before you hit
Hmm.
menopause.
Do
So
it kind of proactively or preventatively.
exactly. And it's great for people who don't want to do filler and they're kind of worried about looking overfilled or not natural. Sculptra is very natural. It's using your own, it's a biostimulatory injection. So it's using your own body's collagen producing ability. So it's
Yeah,
pretty
that's
cool. Yeah.
fascinating. There's always something new when it comes to
Yep.
skincare, and I love it.
Yeah.
But yeah, I think the basics are the basics, right?
Hmm.
Sunscreen, moisturize, keep your skin clean. And
Yep.
yeah, for me too, like when it comes to full body health, I'm like sleep, exercise,
Hmm.
control your stress, and eat a lot of plants and good protein. And that's
Yeah.
all I can tell you.
I know. Easier
So
said than done, but we
yeah,
try.
much
We try.
easier said than done. But that
Yes.
really is the foundation. So we have there's a lot in social media, right, about estradiol cream, and people are putting it on their face, and they think, is this is going to improve my wrinkles, produce my like aging skin, reverse my sun damage. What do you kind of know about like the actual efficacy and the safety of that?
Yeah, and you would think, like, I mean, we've been talking about estrogen declining and estrogen kind of being the source of our collagen
Yeah.
production. So theoretically, you would think it makes sense. And there was actually just a little systematic review that was done in the JAD, the Journal of the American Academy of Dermatology, actually just last month, I think, because of all of this hype around it.
Mm,
But essentially, what it says is, A, there's very few studies. A lot of the studies that did show some benefit came out like decades ago. So some of the ones I was looking at came out in 1996 or the early 2000s. And they were looking
yeah.
at estradiol versus estriol cream. And some of them did show some improvement in like skin laxity and thickening of the skin. But overall, like these were really small studies of short duration. A couple of studies did mention that an adverse effect was hyperpigmentation, and we
Hmm.
know that estrogen can, as high estrogen states such as pregnancy, can induce melasma, which is also a really tough condition to treat. It's basically hyperpigmentation that we see due to hormones plus UV light. And so, some of these topical estrogen creams resulted in hyperpigmentation. So I think you have to be careful if you have a patient with melasma. Theoretically, you
Hmm.
wonder if it could make acne or rosacea worse. The studies that I saw did not worsen those two conditions, but essentially, I think before we can really recommend this across the board, we just need better studies.
Yeah.
And so it is interesting that it's kind of trending right now. And I've seen on TikTok people are trying to put their vaginal estrogen creams on their face, and you can get estrogen creams compounded, and some dermatologists do, but I don't do it
Yeah.
really with any kind of
Yeah.
degree of what, yeah, in my practice.
Yeah.
Yeah, I
Yeah.
think
And I think,
tretinoin is just the better option right now.
yeah. And I think, I mean, you're totally right. And I think this is the trend in menopause care and women's health in general, is that there's just so many gaps in our knowledge. And there's a lot of, on social media, there's a lot of guessing, a lot of theoretical treatments that are coming out, and people kind of want to try anything and everything. So yeah, when patients ask me about using cream on their face, number one, the one thing to know is that the only cream that is FDA approved is the estradiol cream, which is the vaginal form.
Hmm.
And when you mention people on TikTok are putting a vaginal cream on their face, I mean it's just an estrogen cream, so
Yeah,
that is what people are putting on their face.
yeah.
And it's a low dose, and it's safe. There's not much systemic absorption, but absolutely like agree with what you're saying. I always tell patients like you're really kind of doing this on your at your own risk, because we don't
Hmm.
know that much about it, and we know that estrogen can cause like hyperpigmentation, melasma, etc. So, um, you have to, I always tell patients you can try it. I don't know that you'll see great results, but
Right.
you have to be aware of the effects, the possible side effects, especially if there's any history during like pregnancy or teenage years of having hyperpigmentation type
Hmm.
disorders. Like women of color, I'm always like very, especially
Yeah, I
wary of it.
agree. Yeah.
Um, yeah, I mean, there are some other formulations of creams that are out on the market, like estriol creams, but these are mostly compounded and given by like the telehealth platforms like MIDI and Hims and Hers. And they're
Hmm.
really, estriol is a new compound, a new type of estrogen, similar to
Hmm.
estradiol, and it is getting a lot of um, positive reviews, but positive results in
Trust.
studies. But right now, it's really not FDA approved. It's thought to be a slightly weaker form of estradiol, but really the theoretical side effects are the same as using the estradiol cream as of right now.
Yeah.
So yeah,
Yeah.
very interesting stuff about skin.
Yeah.
So tell me a little bit about like, so let's talk a little bit about acne, right? We already mentioned how it's, some women never have it in their life and then it shows up in their late 30s or 40s. And amongst everything else, it's just another really annoying part
Stressful
of getting
thing. Yes.
older. Um, so, you
So
know, uh, we kind of talked about how like acne is thought to be mostly a result of this relative androgen excess, right? And it's probably not helped by the fact that midlife can be a time of increased stress, and cortisol and adrenal gland overdrive, maybe a
yeah.
little bit.
Yeah. I think
Um,
that make a difference.
yeah, one of the things that I always make sure I ask women about is what medications they're taking and if they're taking any supplements, because I think a lot of people don't realize the side effects of some of these. And the biggest one that we see in our clinic is testosterone pellets.
Hmm.
So, testosterone pellets are not FDA approved or regulated, and they tend to be really high dose testosterone, which
Hmm.
is exactly what we know can create acne and hair loss.
Hmm.
Um, and what's kind of like sometimes a little bit scary is that women will get a pellet, they'll feel amazing, and then they'll come into the clinic and their testosterone level will be like through the roof or as high as a man's testosterone level. And they really didn't realize that their levels could get that high, and they didn't know that acne could be a side effect or hair loss could be a side effect. So I always try to screen patients, make sure they're check on their pellet if they've taken a
Yeah.
pellet. The other things that we like always look into is is there any history of PCOS, polycystic ovarian syndrome, and there's a whole clinical syndrome characterized by like hirsutism, like some excess facial hair, period irregularities, etc. And it can be sometimes a difficult diagnosis, and some women really don't get diagnosed until later in life. Like they may have had a fairly normal reproductive life,
Hmm.
have their kids, but they still do have elements of PCOS. And as they're hitting the perimenopause, their hormones are getting a little more volatile, and then they're showing up with some of these characteristics like acne. I also like. I think it's really important for patients to know that there is a risk of androgenic effects when it comes to progesterone therapies, especially some of the synthetic progestins, the ones that are used in hormonal oral contraceptives. Some are known to be more androgenic, and some are actually anti-androgenic. So, the ones that we consider a little safer, we use them in PCOS patients or perimenopausal patients who are worried about acne, tricycline, Yaz, the estrous step, right? And there's also one called Slind, which has become really popular, and it's got a compound called drospirenone, and drospirenone is similar actually to spironolactone. It's an anti-androgen, and it has shown to kind of help with some of the sort of high testosterone effects that happen in perimenopausal women. Yeah, so like what do you
Yeah.
do, Dr. Likhari? Like how do you kind of approach these women from like a derm perspective?
Yeah. So you have to look at the bigger picture first, like you mentioned, because not everything is tied to perimenopause. There's again, acne is kind of multifactorial. There's always a genetic predisposition typically involved. There could be some, other medical problems going on like PCOS. You mentioned supplements like the testosterone pellets. I also ask a lot about biotin. If patients are taking biotin for their hair loss that they just bought, from the drugstore, biotin can actually cause acne. So if you've got new
Hmm.
onset acne, it's something to think about. Certain neurologic and psychiatric drugs like lithium can cause acne. So, try to look at the big picture first. And then I try to characterize what kind of acne is this? Is this comedonal acne, meaning are we just getting whiteheads and blackheads? Is it cystic acne where we're getting deeper cysts, painful stuff? Is it super inflamed? Because that also affects how I will treat it. So if it's just comedonal, a lot of times we can just use topical medications like, again, tretinoin, our
Mhm.
go-to for so many things, because it helps with skin cell turnover, helps to unclog pores. But if we're starting to get inflammatory things, which and most, of that adult female hormonal acne does involve deeper cysts
Mhm.
along the jawline, we do usually end up having to get on something oral. And so one of my go-tos, as you started to mention, is spironolactone. It's an oral, actually, it's a blood pressure medicine and a diuretic at high doses. But at lower doses, we use it because it also blocks the activity of androgens, testosterone, at the level of the hair follicle. So it actually can be used for both hair loss, like that female pattern hair loss, and unwanted hair growth on the face, which we can sometimes see in perimenopause and in cystic acne. And so the spironolactone is a good one. And then you mentioned the three um, oral contraceptives that are FDA approved for acne, Estrostep, Yaz, and orthotricycline. Sometimes we'll
Mhm.
introduce those. Those have drospirenone, which has about like equivalent of 25 milligrams of spironolactone. And then we're trying to usually when we're trying to treat women with spironolactone, we're trying to get to about 100 milligrams. That's kind of the dose that seems to be the most effective. Um, and so yeah, between topicals and spironolactone, those are kind of the mainstays. Sometimes I'll even get spironolactone compounded into a cream for women who can't tolerate it by mouth.
Mhm.
And so that's kind of an interesting way to approach it. And then finally, like for severe cystic acne, Accutane or isotretinoin is the gold standard, really. Isotretinoin helps with every aspect of acne except the hormonal aspect. So I'll usually tell patients, like, if you've got terrible acne, we can do Accutane. There's still a chance, especially if you're a woman in your 40s and going on to your 50s, that you will still end up on spironolactone after a course of Accutane. But the nice thing about Accutane
Mhm.
is that it does cause some lasting change in the skin cells. It helps to shrink oil glands. It helps cell turnover even when you're done with the medicine. And the medicine is nice because it's a finite course. It's 6 to 9 months and then you're done, as opposed to getting on something like spironolactone where you may be on it for a couple of decades. I usually warn my patients who started in their 30s, you're probably not going to be able to get off of this medicine if you are predisposed to
Mhm.
having this type of acne. But it's okay to take it long term. I mean, many people take it for their blood pressure long term, and eventually, when you hit menopause, you'll likely be able to get off of it. So
Yeah.
I'll throw in Accutane sometimes just to help, but then knowing that there's a hormonal component, we may still be on spironolactone for a while.
Yeah. Yeah, absolutely. And yeah, I think spironolactone has great efficacy for the hormonal component
Hmm.
of acne for sure. I've seen that. Um, so let's talk about hair. Um, we just have a few more minutes, and so we will. So we talked about the different types of hair loss and kind of the workup of it. What do you recommend for like treating hair loss? So you have a woman, maybe like, yeah, what do you do? How do you kind of approach the treatment part of it?
Yeah. So, first of all, I like to set expectations with hair loss because
Yes.
we, what I usually tell people is that once you have something like female pattern hair loss or even male pattern hair loss, it's like a train. The train has left the station and it's going to keep going. It's just going to progress as you get older. So the treatment is aimed at putting the brakes on that train. If you stop the treatment that we're prescribing, that train will take off again. So whatever we do for hair loss is something you're going to be doing long term if it's something that continues to bother you. So I usually start, the gold standard for most hair loss is minoxidil. Minoxidil, again, is a blood pressure medicine. It dilates blood vessels. We don't exactly know the mechanism of why it works in hair loss, but it does have the most studies showing efficacy. We think that it's just because it's kind of improving blood circulation to the hair follicle. But you can do topical minoxidil, which is brand name Rogaine, which you can buy over the counter. And I usually recommend 5%, the 5% strength.
Yeah.
And it's something you put in your scalp every single day and you continue that lifelong. You can do oral minoxidil, which more and more people are kind of using nowadays. It can cause some unwanted hair growth, which women don't love. So we kind of have to balance that. Both types of minoxidil can cause increased shedding. There's like a paradoxical increased shedding that people can have for the first 3 months. So I always warn people about that. But once you kind of get past that hump, that's when you start to see a significant improvement. But
Yeah.
you're
And I
not
think
going to,
it's, yeah.
no,
Sorry.
go
And
ahead.
I was gonna say, yeah, I think it's important for people to also know that they have to, once they start this, they kind of have to use it indefinitely,
Yeah.
right? Because
And
once they stop,
they really
yeah.
have to use it for at least 6 to 12 months to even know if it's going to help them. So you kind of,
Hmm.
yeah, and a lot of people give up too soon. And that's the
Yeah.
other thing with evaluating hair loss is we're not necessarily going to see a bunch of new hair growth. So our benchmark for whether it's working is, are you at least stable? Are you not getting worse? And if those two things are happening, then we would just continue with the medication. Um, and then for scarring types of hair loss, like the frontal fibrosing alopecia, we'll do minoxidil, but sometimes we'll also throw in an anti-androgen medication like dutasteride or finasteride. And then
Hmm.
again, spironolactone we talked about can be helpful too for its anti-androgen effects. But hair loss is just, it's a very frustrating, it's a frustrating condition. And at some
Yeah.
point you may decide, I'm sick of treating it and I'm over these medicines, and that's fine. You can always choose to stop doing them, but you may go
Hmm.
through like a little shedding phase to get back to your baseline. And the last thing I was going to say is that we all also will use PRP or PRF injections for hair. Lots of studies showing benefit in female pattern hair loss. Um, and again, it's just because the thought is that there's growth factors that are stimulating those hair follicles when you inject it into the scalp. So,
Yeah.
yeah, I mean, hair is
Yeah.
challenging,
No,
and
I
like you said,
agree.
there's so many things contributing to it, but there are at least some options that we have.
Yeah, I agree. And I think, studies when it comes to like hormone, I think we have, these are the medications that are best studied. And I think when it comes to hormone
Yeah.
therapy, there's just so much unknown right now. And it's sort of some people, may think that it helps and some people don't. And it's a very anecdotal, observational kind of thing.
Hmm.
I've definitely seen patients respond to hormone therapy when it comes to dry skin. So I imagine
Hmm.
it has some effect on the dryness of their face as well, because
Hmm.
there's just so much like dry arms, dry legs, and definitely they respond to that. With hair loss, it's really hard to say, whether systemic estrogen cream and progesterone supplementation actually can improve hair loss. But yeah, I'm with you. I always focus on like all the internal health and try to control what you can control. And
Hmm.
then there's just a part of genetics, which I think like what can we do about it?
Yeah,
Right? So
yeah. And there's clearly gaps, like as we've mentioned, this kind of the
yeah,
theme of this discussion is that there's so many gaps in knowledge. Like
so
all
many
of the
gaps.
medicines that we have that we use for hair loss have kind of been adopted from what we use for male pattern hair loss, which is a little bit more clear
Mhm.
cut. I mean, in men, they have a higher activity of DHT at the hair follicle as well. So we have all these anti-androgen medications, but we also know that in women, the decline in estrogen plays a huge role in postmenopausal hair loss. And it seems like we just don't have great studies with hormone replacement, specifically looking at hair loss as an endpoint.
Yep, we really don't.
Yeah.
Yeah. All right. Well, I think this was a great discussion. Thank you so much for Dr. Likhari for all your expertise. I learned a lot, and I will definitely be sending more hair loss patients to you for an evaluation, a proper evaluation before assuming it's just stress and hormones. Um,
Thank you so
and
much for
yes,
setting this up, Dr. Kumar. And you're
yeah,
going to be getting a lot of my patients who are complaining of all the other stuff, brain fog,
yes, yes.
anxiety.
Absolutely. And really, thank you so much. And thank you to everybody who's listening. And we will see you later.
Bye.
Bye.